All right. Good morning, everybody. Thanks for staying with us. So, for those of you who may not have worked with me, Chris Nolan, of the critical care faculty, with Dr. Emily Davis, and Dr. Jason Bartok.
AV team, that's all.
Yeah, AV team, AV club. So thank you guys for joining us. The purpose of this was really to provide some education around ECMO. I know we've had a lot of patients, throughout COVID, and then our volumes sometimes can fluctuate. So the skills we've learned can wax and wane based on the number of patients that we have. And so I think this is the first in a series. We'll kind of try to keep this up for you guys to make sure that we keep up our skills and also share some of the rationale of the management choices that we make for our ECMO patients. And so the setup today is we're going to share with you a lecture that we typically give actually for our critical care fellows to give you a little bit of insight into the physiology and the decisions that we make about ECMO. And then we'll have some hands-on time with the circuit, which for those of you who have helped with who have managed the ECMO patients, are familiar with, but I think it's good to troubleshoot various scenarios and just have hands-on time where you're actually doing things with the circuit as well. So with that, I want to say thanks for joining. Please ask questions. It's meant to be interactive, so at any point, if something doesn't make sense or you have a question about what I'm saying, just please interrupt. Cool. So just an outline. So we'll go through an introduction of ECMO in general. We'll talk about our patient selection for VV and VA. We'll talk about the ECMO circuit and its components. ECMO physiology, how do we manipulate the machine to achieve what we want to do? How do we monitor these patients appropriately? And then how do we troubleshoot various scenarios? So what are some of the learning objectives? So understand the indications, contraindications for ECMO support. Be familiar with the components of an ECMO circuit. Understand the common ECMO configurations. Understand how to manipulate ECMO settings and achieve physiologic goals. Understand the importance of placing an arterial line in the right upper extremity on VA ECMO, and we'll talk about why that is, and in some cases actually when that may be slightly different. Understand the concept of venting the left ventricle for patients on peripheral VA ECMO, and then become familiar with some of the common troubleshooting scenarios that we may encounter very infrequently but need to know what to do. So, introduction. All right, so there's two main flavors of ECMO. So one is VV ECMO, and so this we use in patients who really just have primary pulmonary failure. So they typically like our ARDS patients. Okay. And so we use this when the heart is functioning fine, but the lungs are down, right? So we're taking blood from the venous side, we're putting it through ECMO to oxygenate the blood, remove CO2, and we're putting it back into the venous side. And as you can see, this kind of cartoon, you're going into the vena cava and mixes in that right atrium, and then the heart takes care of the rest, pumps it to the rest of the body. And so blood is going through the lungs after it's been oxygenated. The lungs may not effectively work or may not work very well, and so you may not get much additional oxygenation or CO2 clearance because of how diseased the lungs are. But that's okay because we've already done the job. The other major flavor is VA ECMO, and so there's a lot of ways that you can configure these cannulations in both VV and VA, and we'll talk about that a little bit later. But in VA, think about it as you need cardiac support plus or minus also pulmonary support. So the heart's down and maybe the heart and the lungs are down as well. And so we're draining blood from the venous side, we're putting it into our arterial side, and so the main difference here is that we're providing our blood pressure support, so perfusion, by going through the arterial system. So when we use ECMO, the main thing we're trying to do is give us more time. So most of all the things we do in the ICU is really to give us more time, support the patient so that we can do some sort of intervention, whether that be go to the cath lab or surgery or what have you, give time for antibiotics to work, or time to make a decision about what we do next. In some patients with severe lung disease, that may be transplant. So patient selections. How do we pick our patients that go on VV or VA? So main indications for VV ECMO, as you might think about, is really refractory hypoxemia or hypercapnic respiratory failure. So elevated CO2, low pH, low oxygenation. You can also think about scenarios where maybe you have a severe air leak, so that patient has a chest tube and you just see air blowing out, and the amount of air that we put into the ventilator is just leaking out through the chest tube, so we're not really effectively ventilating the patient. The other thing would be a patient who's on a lung transplant list. That may be a patient who gets intubated, they go immediately on ECMO so that they can do physical therapy and things while they're waiting for their lung transplant. And then you can think about scenarios where you have an immediate blocked airway where there's no way to intubate, or the airway is totally occluded and then they emergently go on ECMO. So what are the contraindications? There's no real absolute contraindication, but some of the things we think about are, is ECMO going to benefit the patient, or are the risks of putting them on ECMO outweighing the benefits? So some centers and us we consider as things like if they've been on the ventilator for more than 7 days, particularly if they've had high ventilator settings. So the idea there is that there's been a lot of damage done to their lungs, and the likelihood of recovery is significantly less than someone who has been on for less amount of time. The other things would be age, comorbidities, multi-organ failure. So patients that are probably, unfortunately, too far progressed in their pathology that putting them on ECMO is likely to change that outcome. And then recent or expanding intracranial hemorrhage. And you guys probably look at this list and say, oh, well, all of these things we've done, we've put patients on ECMO who've met all of these contraindications. And that's true. It's kind of, again, a lot of it's relative. And if we think it's something that is potentially reversible, buying that time to recovery, that's really what we're trying to achieve. So what are the kind of criteria that's put out by ELSO? And so our guideline recommendations for when you put someone on VV ECMO. This is, a lot of it's done based on a trial called the EOLIA trial that was published in New England Journal of Medicine, where they randomized patients to early ECMO versus waiting and seeing if they end up needing it as a rescue therapy. And so those criteria are particularly a P to F ratio, so the PaO2 divided by the fraction of inspired oxygen on the ventilator of less than 80. We really should be start thinking about ECMO for refractory hypoxemia. So you may see that the pulse ox is okay, but the amount of support that they're on to achieve that is really indicative that their lungs are really diseased. The other thing would be if we look at our ABG and we see a pH that's less than 7.2 and our PCO2 greater than 60, so saying the patient's lungs are not able to clear CO2 despite having gone up on our ventilator to really high settings. So they talk about respiratory rate of 35, which oftentimes if you think about the patients we have on the vent, you don't even quite get to 35. That's a really high rate. And also making sure that our settings on the ventilator are safe. So we talk about airway pressures. So you guys may have heard, think about plateau pressure. So when that's greater than 30 centimeters of water, something we keep in mind is that's indicative that the lungs are very stiff, and that's kind of indicative of how severe the lung disease is. So meeting those criteria, so just think refractory hypoxemia, refractory hypercapnia, so we're not able to clear CO2. And in those cases, that's when ECMO would be indicated for VV. Questions about that? So what about for VA ECMO? So a couple of indications. So one is cardiogenic shock. That's probably the most common thing we think about for patients that we put on. And that can be in the post-cardiac surgery patient or a patient who comes in de novo with cardiogenic shock from an MI, STEMI, from myocarditis, maybe a viral process that their heart's not functioning well. We can think about eCPR, so someone in cardiac arrest, they get put on ECMO during cardiac arrest. I think something that you guys will see way over the near future to come at Cooper, how regular that would be. And then question mark could put for septic shock. So you might think, hey, we have these patients who they have this infection, they're in profound shock, they're on 3 pressors, like why don't we put them on VA ECMO? In select cases where the heart function is affected, so they also have cardiogenic component to their shock, those outcomes in the literature have been relatively good. Those who have normal cardiac function, septic shock, do extremely poorly. And so those aren't the patients that we would reach to put on ECMO typically. What are some contraindications? So absolute. So if they have an unrecoverable condition and they're not a transplant candidate or a candidate for a durable ventricular support device, so an LVAD, then it's not a patient we want to put on ECMO. It's really just kind of, there's no way they can go with that support. So think like end-stage heart failure, they're not a transplant candidate, they're not a VAD candidate. This isn't something that's going to get better. It's not the patient we want to put on VA. And then relative contraindications, similarly, contraindications to anticoagulation, age, comorbidities. So with VA ECMO, you're higher risk of, if there are clots that form in the circuit, where those end up going and cause strokes and other things, whereas VV ECMO, we're going to the venous side. So it's not going to cause a stroke per se. There's a little bit more tolerance of not being on anticoagulation. So something we consider with the VA ECMO patients more. Just to give you guys an example of patients that go on eCPR, so those in cardiac arrest who end up getting cannulated for VA ECMO. So there's a trial in 2020 called the ARREST trial. And so they enrolled patients that were 18 to 75 years old. Their initial rhythm was VFib or VTAC. And then they were out of hospital arrest that had a transfer time of less than 30 minutes to the ED. They didn't put people on if they had criteria that suggested that they kind of had too far progressed in their cardiac arrest, so they had an tidal less than 10, they had lactate that was greater than 18, or their oxygenation was extremely poor, just as part of their criteria for their trial. So just an example of things that might be considered for an eCPR program of how you're evaluating that patient, whether they get cannulated for VA ECMO or not. That's going to be ultimately determined by the site that you're at and what they've decided to do. All right, so let's talk about any questions about that, indications, contraindications, maybe patients that you've seen that we put on, why they did or did not go on.
What about BMI?
Yeah. So BMI, I think, poses some challenges with cannulation, and then maybe some considerations in terms of like how their recovery with rehab and things. But when we've looked at the literature, and Emily maybe want to chime in, it really hasn't been. I think it's been a traditional contraindication or relative contraindication, but in terms of the outcomes, I believe the literature we looked at were similar.
Yeah, it's interesting because in that scenario, sometimes the large abdomen, heavy chest wall contributes to higher weight pressures, and that's not actually a lung problem. That's like a habitus problem. So in some cases, that might be sort of protective for their lungs. But the outcomes, and there was actually just another paper published. I was going to talk about it in our meeting again, but we've gone over so many of these papers that the theme is, at least retrospectively, they do just as well. And other than, like he's saying, the anatomic consideration, the other consideration is they have such a high body surface area. Their needs for flow are very high. So in a couple of our obese patients, we had to actually put in a second drainage cannula because we simply couldn't flow enough. So that's another thing to consider with a high body surface area, but it is not an absolute contraindication. Now, do some programs sift based on that? I don't think ours does, but yes. And then it does implicate transplant candidacy, very much so. So if that's your bottom line and you're irrecoverable, unfortunately those patients probably aren't candidates for transplant.
Yep. Anything else?
For the VV ECMO, do we necessarily have to prone them first before we, like, I feel like for some of the COVID ones, we're like, well, let's prone them first, see how they do, or like, let's reevaluate this tomorrow, or like that kind of thing.
Yeah,
you have to do that.
You don't necessarily have to. Guideline recommendations from ELSO, so Extracorporeal Life Support Organization, right?
Yeah.
Basically like the kind of head agency for ECMO, and they have a registry that Emily does all the work for, where we kind of collect data on patients, but they put out guidelines for various things. And for VV ECMO, they recommend a trial of proning unless contraindicated. The reason being is that when we prone patients, it has been shown to reduce mortality for patients with ARDS. It's a relatively non-invasive thing where ECMO comes with a lot of other complications. So if a patient doesn't have a reason we can't prone them, then that's a reasonable thing to try first. Now, if we think like, oh, proning is just going to like make everything look better for a little bit, and it's not going to get them through this, that we'll avoid ECMO, then that may be a decision we just put them on ECMO. Now, COVID, I think, is a little bit a different beast. I think all of us saw, we struggled with, how these patients were doing, and kind of were, for a while was ECMO the right thing, we were thinking at some points. And that's borne out in literature that it did help a lot of patients, and we saw that too. but trying to do to make very strict selections about who we put on ECMO because outcomes for them were very much a fight, a struggle, and if they could get away without going on ECMO, then the best thing for them. Make sense? We'll talk about the circuit. So we'll talk about the components of the circuit, and you'll get a chance to go hands-on up here. But for those of you guys who've been at the bedside, maybe well familiar with these, but we'll talk about kind of specific things and how we manipulate it to achieve what we want. If we look at our circuit here, let's see if I can make this. It's kind of lagging. But we can see in the blue here, so when we start, we talk about our drainage cannula, and we have our return cannula. So we use the terminology, and also has shifted to this as well, that our terminology is that we talk about a drainage cannula that's draining blood, taking it to the ECMO circuit, and then returning it back to the patient. And that kind of gets away from talking about the venous cannula, the arterial cannula, and some other terminology that was older from cardiopulmonary bypass that was very confusing. So that's the terminology we use here. So drainage cannula, that can be in any kind of venous location, and then a return cannula, which could be in a vein, could be an artery, etc. So we look at our circuit, right? We have our drainage cannula that's being pulled towards our pump, and our pump is controlled by the controller. And so that's the biggest thing we see on the ECMO card, where we're controlling the RPMs of the pump that's spinning, and then ultimately that determines what the flow is based on the resistance throughout the circuit. So once the blood reaches the pump, it's then going to be pushed towards the oxygenator, which think of this much like dialysis filter, right? We have blood going one way, we have a combination of air and oxygen, or just oxygen going the other way, and then there's exchange between those two. Oxygen moves into the blood, CO2 moves out, and then voila, you have well oxygenated, well ventilated blood. So coming out of the oxygenator, I depicted the warmer as a separate component, but you guys will see when we go up to the circuit, and you've probably seen it bedside, it's not really separate in that setting. It's just easy to see this way. It's usually hooked into the oxygenator where there's warmed water that's circulating and keeping everything warm. So think about like our patients on CRRT, right? We often have to put them on a bear hugger because they get cold from the exposure of the circuit, even more so with ECMO. So this helps us to control their temperature. You guys will see that blender there, and so what that is there's liters per minute of gas that's going through the oxygenator, and also the FiO2 of that gas. And so typically, most often, we have patients that are on 100% FiO2, but as they're getting better and better, and we're kind of getting towards, moving towards coming off of ECMO, that's when we might start titrating the FiO2 down. We don't want the PaO2 when we check our ABG for the patient to be 350. We'd rather have it in a normal range. And so that's why we might titrate down the FiO2. But typically, we're going to start at 100%. Go from there. All right, so this is kind of pictorially, you guys have seen this. So the controller up on the top right controls the RPMs of the pump. We have the blood warmer down there. We have a pump head. And we have an oxygenator. All right, so what are some ways that, we'll talk about how we manipulate those settings in just a minute, but what are some common cannula configurations for various types of support? So let's talk about respiratory support, so VV, and there's also other ones. So what about VV ECMO? So this is probably the most common one that we do here, where we have a drainage cannula that goes into the femoral vein and up into the inferior vena cava. We try to put that right where the inferior vena cava meets the right atrium. And then we drain blood there and we return it through the right IJ. So blood's coming to the right IJ. And then once it gets into the right IJ, into the superior vena cava, it goes into the atrium, and then the heart pumps it to the rest of the body. Another configuration is the femoral axis. So you may have seen this. So if we have a reason what we don't want to go at the veins in the neck, for whatever reason, then we'll do femoral cannulation, so both femoral veins. And here you'll notice we have the drainage cannula is the one on the left-hand side. So look at the right-hand side of the screen, the cannula that's on the left-hand side of the inferior vena cava with all the holes on the side, that's our drainage cannula, and it's not going quite as far in as our return cannula. And the reason for that is you want the blood to get to the atrium and then be taken to the rest of the body, and not vice versa. And then we also have the dual lumen cannulas. So you may have heard the term Avalon cannula. It's a brand name. There's also the Crescent, and there's another one on the market. But what these are is they're all in one thing. They have different holes that for the different lumens for the drainage and the return. It's all packaged in one thing. It comes through the right IJ and then transverses the right atrium across the superior and inferior vena cava. And why might you use this? It's you're getting rid of the femoral access, so mobility might be a little bit easier for the patients, and that's kind of the main thing with that. Or if there's a contraindication to going for the femoral sites, and that may be a reason why we choose to put one of those in.
How come you commonly don't use the Avalon? I know there's some reasons why you don't always choose that kind.
Yeah, it's technically more challenging to put in. It has some, it's very finicky in terms of so if you guys look at this cartoon, you can see that red arrow is supposed to cross across the tricuspid valve. It's supposed to point at the tricuspid valve. You can imagine the patient turns, it gets twisted, it's pointing in the wrong way, and so the oxygenation is not nearly as good as what we want it to be, and so you have to readjust it. So we had a patient that a lot of you guys may remember in ECMO who's on, or in COVID, who's on for 3 months with us and ended up going to Temple. But she had one of these, we had to manipulate it all the time. So do an echo, twist it around, resuture it. They're very finicky.
What would you say if it's not in the proper place? What will you see clinically in the patient?
So you might see that their pulse ox goes down. So it's not as effectively oxygenating or ventilating them. Any questions about these configurations and why we might choose one of
I
them?
just have a quick question.
Yeah.
I think I heard before something about the Avalon and pulmonary artery pressure. Does that have any effect? It increases it less than the government, or is that not?
I'm not familiar with any data that says that.
I don't know. Yeah.
It doesn't provide any, so we'll talk about another configuration. This doesn't provide any support to the right heart.
Right.
So a lot of our patients with ARDS, they end up with right heart failure or right heart dysfunction. And so, this unfortunately doesn't provide any help for that problem either. But in terms of that versus the other ones,
No difference.
no difference. Right? So this one actually does provide support to the right heart, and something that you may see more and more. We haven't done one of these here at Cooper yet that I'm aware of, but this is a nice solution for patients who have right ventricular dysfunction. And so what this is we have a drainage cannula like before in the femoral vein going up into the inferior vena cava, draining the blood, going to ECMO, and then coming back. The return cannula goes from the right IJ through the right atrium, right ventricle, and into the pulmonary artery circulation. So think of it like your PA catheter. It's essentially a cannula that's in the same location as your PA catheter, and then the blood goes into the pulmonary artery. So why might you think about that? If the right ventricle doesn't pump, this bypasses that. So this is, you may have heard the term, so like LVAD, we have RVAD, right ventricular assist device. This would be a form of that. So a patient with isolated right heart failure, this might be a solution.
Chris, do you want to mention why we flow all the way back, not in this configuration, but the normal configuration, all that flow into the right heart that might not be good for anybody?
Yeah, so just looking back here, if we, so we'll talk about how we manipulate the circuit, but sometimes we might have to flow at a very high blood flow rate. And you think about, look at this arrow and where that's shooting that blood. It's going to shoot really high pressure blood, right at that right ventricle. It probably isn't used to seeing that effect. And so if we have patients flowing on 5.5 liters a minute, it's really probably not the best thing for the right ventricle. It's not helping, but it may also inhibit its function by pushing all that blood there. So. You might say, why don't we do this on every patient then? So I think it adds a level of complexity, one with placement and then also with weaning, whether this is, we need to, whether our right heart is supported or if we can come off ECMO, whereas VV, we'll talk about weaning. With our other configurations, it's pretty simple of how we kind of determine whether they're ready to come off ECMO or not. All right. So what about for VA? So this is where things, especially with Dr. Minicata, can get really interesting. So VA ECMO, kind of the simplest way to think about it is you have peripheral VA ECMO. Okay, so what we're doing is we have our drainage cannula that's in a similar position to VV. Sometimes we advance it further, so it tries to capture all the blood from the upper body and lower body, so we advance it a little bit more. And then we drain that blood there, we put it to ECMO, and then we put it back through the femoral artery. So coming through the groin, up into the aorta. And here you'll notice that blood flow, so think about where that blood flow is going. It's going up the aorta, so it's going backwards up the aorta. And we'll talk about some reasons why that can cause problems. But this is a very simple way. It's very technically the easiest to put someone on peripheral VA ECMO versus other configurations, and probably the fastest too. So this is often when people talk about ECPR, this is how they put them on. So femoral vein, femoral artery. So another configuration that you may have seen is the central cannulation. So this is typically going to be our post cardiotomy patients, so cardiac surgery. So this is something that Dr. Minicata is very comfortable with. And so what you see is there's a drainage cannula that's anywhere, possibly in the right atrium, draining blood there. And then the return cannula is usually in the proximal aorta. And so this has some benefits. So we talked about how the last slide that the blood flow is going up the aorta, kind of backwards and against the heart. This goes with the heart, so it doesn't really compete against the native heart function. And also we'll talk about some other reasons, but it perfuses all the vessels of the upper body very easily. But what adds complexity is bleeding, central access, it's very invasive. And so not one we typically go to as a first line. Now kids, this is often what they go to first line. All right, and then there's many, oh yeah, go ahead.
Just have a quick question. How many times can a patient be centrally defibrillated in their life?
That's a great question. I don't know the answer to that.
That's
probably
loaded
dependent on the surgeon.
I was
Every 10 years?
under the impression it was only like twice, but I'm not sure because we almost ran into that situation with a patient on our unit.
Yeah.
And so I wasn't sure whether, because I had heard somewhere in literature that it said that you can only go on a certain amount of times.
Yeah, it's probably related to the surgeon's comfort, but to the complexity of the cases that came before, kind of what scar tissue they have, where they were cannulated, where they're available to put in cannulas or even just open up sternotomy. So you think about sometimes we have patients who have multiple abdominal surgeries. Have you ever heard the term frozen abdomen? It means that essentially they've had so many surgeries that there's so much scar tissue that the surgeon's not going to go back in there. So you could think about a scenario where that could end up.
Unicut will be like 5 times.
Yeah. And so there's a lot of different configurations. So I know it's a little hard to see, but we talked about femoral on the left-hand side, in the middle of femoral axillary artery. So we had a patient recently with this, I think bed 5, had it coming from the right axillary artery and down. And so it's less invasive than that central cannulation we talked about, while also trying to achieve some of the same benefits of where the blood flow is coming back. And then you could think about peripheral jugular axillary VA ECMO. This might be more like a child, or depending on the vasculature. I haven't seen this personally here. And then we have the central cannulation. So lots of ways that you can do it, and it's really about drawing it out, thinking about where that blood's coming back, to think about what does the physiology look like in that setting.
I have a question.
Yeah.
I know we don't deal with kids, but why is the cannulation different with children? Just
Why is it
because of the
different?
vasculature?
A lot of I think the vessels are small.
Yeah.
And so access. She got the
Yeah,
other
no,
side.
vessels are small, access is a challenge, and it's just the way it's been done for a long time. They do really well. think they don't have carotid disease like an adult does. They don't.
Exactly.
Yeah.
And
So
healthy.
it would be easier to just centrally do it because those are larger vessels.
Yeah, so they'll either do it centrally, a lot of them actually go to the carotid artery. So they put that return cannon into the carotid artery, which in an adult stroke, but in kids, they actually can ligate that off and there's no problem. They just perfuse their brain from the other side.
When I was in residency at Duke, the first ECMO case I ever saw was a 10-year-old who came in with a viral syndrome and decompensated in our pediatric ER and went into cardiogenic shock and actually then went into cardiac arrest. And during compressions, the cardiothoracic surgeons at Duke put him on VA through the carotid. It's really crazy. I didn't really know anything about ECMO as a resident, and it was pretty impressive. So yeah, I think it sort of speaks to their lack of carotid disease. So if they go peripherally VA, that is the site that they go. Seems crazy to us, but.
Yeah, and I don't know, maybe that'll change with like ultrasound access, and traditionally you would cannulate just cardiac surgeons, and they may be more comfortable with just opening up.
Didn't ECMO originate on children? Isn't that when they first started using ECMO?
It's when they first started having success with it, yeah.
Oh, with kids, okay.
Yeah.
The adults were the guinea pigs and then they moved on to the kids.
Well, I think they had pretty bad outcomes initially in the at University of Michigan childhood development. So what are some additional devices you guys may see? So as you've probably seen, this gets like more and more complex. Every patient that comes out is something new that we have to learn, and that we're all learning together, so it's fun. So what are some common devices we may see? So one of the problems with peripheral VA ECMO, as you mentioned, that blood flow is going backwards up the aorta. So think about who we're putting on. Their heart is already weak. It can't squeeze. It can't eject blood. And then, not only to add injury to insult to injury, we now put blood that's going backwards against what it's trying to pump out. So you can think about an extreme circumstance, all that blood that's going up the aorta, no blood is getting out of the heart. So it just builds up in there and doesn't move, and then it can actually clot off. So this is an extreme example you see on there. On the bottom of the screen, there's an ultrasound image. In the kind of bottom right-hand corner of that image is the left ventricle, and you can see it has that kind of more white material in there. That's a clot. The whole left ventricle is clotted off. You think that's an extreme circumstance where the ventricle is not ejecting blood stagnates, it clots. So how can we avoid this, and how do we recognize this? This is where we get into the talk about like venting the ventricle, getting rid of that blood that's stagnating there. So inadequate perfusion so one thing with the peripheral VA cannulation is that you don't get perfusion to the leg. And also, if the ventricle doesn't empty, you can end up with thrombus. Those are some of the complications. So how do we mitigate some of these risks with that? So just to kind of expand on why that happens, so you think about the coordinated cardiac function, you have increased afterload from the retrograde flow from VA ECMO, if it's coming up the femoral artery in the aorta, incomplete or no left ventricular emptying, LV distension, it gets stretched out, distended, pulmonary edema, as it backs up into the lungs, then you end up with a thrombus, and that's kind of the end result. They can't get away from that once that happens. So what are some additional devices we may see? So you can think about a reperfusion cannula. You guys have probably seen this in the patients who end up on peripheral VA cannulation. So what it is a little sheath. So think about like a 5 French, 7 French arterial sheath. It's going, rather than up the leg, like the return cannula is, it goes down the leg. And so we hook this into the return cannula. It sends blood down the leg to the foot, and therefore you're getting oxygenated blood going to the foot. Whereas if you think about, if you didn't have that, think about what you're doing. You're putting a big hose into the femoral artery. So you're not only occluding that vessel, but you're also pushing blood backwards up it. So no blood flow is going to go down the foot, potentially. Some patients may have a big enough vessel, or for whatever conditions they can get some blood to the foot, but most patients will have problems with perfusion to their lower extremity, and so one way we get around that is putting in this extra cannula or sheath to then put blood down to the foot. Make sense? All right, what are some other devices? So we talked about how that ventricle...
I'm sorry,
Yeah.
to interrupt you. Can you So the indication for foresight in a patient on VA ECMO to measure their tissue oxygenation, we have the capability of doing that with our Swan box. So make sure if you have a patient on VA ECMO that you put the monitor on both lower extremities.
Right.
Because that will give you a signal, that'll give you a clue that you're having a perfusion problem before any other indications.
Yeah, a very good point. So that's particularly if you have a cannula that's going in one of the extremities. So you may, so the other thing is, think about this, right? If there's not much blood flow going there, it may be trickling down there. You're not going to feel a pulse. You're not going to feel a pulse. And so, having that the foresight on there, you can see a difference. Oh, the perfusion on the foot that doesn't have the cannula in it is doing fine, and there's a lot less perfusion on the other foot. So, okay, we probably need one of these cannulas. I need to, call in.
And can you add that on? Like, let's say they've already been cannulated for 2 days, you can go back and add one.
You can. It's a little more challenging because you think about that blood vessels. Now it's like really small, and there's not much blood flow going through, so hard to see it.
Yeah.
So trying to do it up front is probably the better thing. And also, like, kind of waiting until the foot's ischemic, that's probably not the right time. So if there's one that's not put in, you should ask, like, why. It should be kind of, that's, I think, as a group, we would like that to be the standard, and it should be the standard. But if there's not one put in, there's probably a reason why, and if there's not, you need to ask why. Yeah.
Would you expect a Doppler will pulse though?
So when you have the perfusion cannula in?
Yeah.
Good question.
We actually had a patient who did have a Doppler pulse, but instead of being biphasic, it was monophasic. So you would only hear one beat instead, and it would just be like whoosh, whoosh.
Did they have the cannula in or no? Yeah. Yeah, that's a good point. So
At least that's what I've experienced.
yeah, so you may only have a mean arterial pressure because it's just continuous flow that's going down to the foot, not pulsating.
Right.
So yeah, just hearing that.
So I know a lot of times you have Doppler checks built into your protocol, but you wouldn't necessarily expect a Doppler pulse because you have just laminar flow. So that's why the tissue ox monitor and things, and sometimes just using color to make sure that they have good flow. There's a lot of questions that you get sometimes when they have no pulse, but the leg's still warm.
So if their foot were to go cold, would we be able to ask you guys to check on ultrasound?
Mm-hmm. Yep. Yeah, that plus the foresight would be helpful. Yep. So what are some other devices we may see? So patients on peripheral VA ECMO where that blood flow is going backwards up the aorta, they need to decompress that left ventricle. We need to make sure it's emptying. So one way we can do that is through a balloon pump on the right-hand side. It decreases afterload, helps the ventricle eject that blood. And the other is an Impella. So Impella is going to take blood from that inlet that's in the left ventricle, suck it up, put it to the outlet, which is past the aortic valve, and help empty the blood from the ventricle. So most often in our patients who are on ECMO, unless they're centrally cannulated, we're going to have a assist device to help to vent the left ventricle, whether it be a balloon pump or an Impella. And probably more, it depends on the case, we may have an Impella 5.5, and the goal would be that that's in there, and once they're ready to come off ECMO comes off first, and then the Impella out later. Or balloon pump, try to get ECMO off first, balloon pump comes out later. Now you can think about a patient who, let's say there's certain scenarios where you may not have this device because you may be on VA ECMO for, let's say, a cardiac arrest where all of a sudden you had to put them on VA ECMO, and now because you got ROSC, their heart function's fine again, and so they're actually emptying their ventricle very well, and so we don't need to put one of these in. Make sense?
Does the Impella necessarily have to be flowing higher than the circuit to like compete against the retrograde flow?
No. So the reason is all you need to do is get the little amount of blood that's in there out of the ventricle from stagnating. So if we look at our cannulation, so look at that blue on the drainage cannula. We're really trying to capture most of what's going to end up going into the right ventricle and then ultimately end up in the left ventricle. But there's still a little bit of blood that goes through there. So most of the blood should be drained through the ECMO circuit. So it's not like your full cardiac output that you normally see coming through the left ventricle. So you wouldn't need to have the impella flow equal or higher to the ECMO in order to eject the blood. It could be.
I have a question also. If you have somebody in cardiogenic shock on VA ECMO and you have an impella and they're starting to get cardiac recovery, what will you see in the patient? What will you see in your numbers on your impella and your, how will you know?
Yeah. So one thing is you often see more pulsatility in your arterial line. So you can see an extreme example on this page. So see that arterial line, it's totally flat, but you look at the mean arterial pressure at 69. So this might be a patient whose heart is not ejecting at all, but you have ECMO that's like putting blood out, or impella that's putting blood out, so that you actually have some perfusion. As the heart recovers, it's going to start ejecting more, and so you'll have that systolic will go higher. There'll be a bigger difference between the diastolic and the systolic. So that's one thing, and then looking at our, I think what else? Anything else you guys think about?
No, I mean, you'll
echo.
start to do bedside ultrasounds and then wean your support and then watch the heart take over the work. But seeing it, and for these extreme cases, which we'll see more and more of them, where you're basically completely flat, first thing you'll see is ejection as the heart wakes up.
And Dr. Gala talks about, you put anyone on ECMO, start all that flow against their LV, it's gonna diminish the native cardiac function. So he's way better. Like, when we had that patient in 5, he was looking at the waveforms and, he's ejecting and not ejecting. I was actually having trouble seeing that nuance. But yeah, from the tracings and then looking with echo, I think you can start to figure it out. He's wonderful, by the way. Ask him a lot of questions. He is a great bedside teacher. He loves working with us. He's wonderful.
When you're impella, I just lost my train of thought. It'll come back. This is what's happening to me now. This is all due to anesthesia, not age or anything. I'll think of it in a minute. Oh, your ability to wean your impella. So when you're going down, you're able to go down on your impella, but your cardiac function improves, right? So you're kind of weaning your impella and you're weaning your ECMO at the same time. And then you're able to decannulate or get off your ECMO, but you're still on your maybe minimal settings of your impella, right? Would that be ideal?
Yeah, and it depends on how the patient's recovering, like how fast you can do any of those things. So any of these, we want to turn them down as much as we can. Like, there's not like a benefit in running it really high unless the patient needs it. So there's issues with traumatizing the red blood cells. You can have issues like the impella. You think about where that device is. So if you try to suck a lot of blood to that inlet and there's not much blood there, you can actually collapse the ventricle around the impella, and then you end up with a whole host of problems that you're not actually getting enough blood flow through, causing trauma, things like that. So that's one of the reasons why we might start weaning down on the impella flow.
Yeah, one of the things you might actually see as the heart regains function is more alarming on your impella, suction events and things like that, as the ventricle wakes up and starts to come in contact with the impella.
One experienced that a lot for you guys that took care of him. Patient bed 1 had similar to this.
All right. What about the physiology? So which knob do we turn? Okay. Actually, let me go back. You guys probably already read it. So maybe I can get from, what do we do to improve oxygenation on a patient?
Change the flow.
The flow, right? So when we talk about flow, we use the term as the blood flow going through the ECMO circuit. So the more blood that we put through the ECMO circuit, the more red blood cells we're putting oxygen onto, more we're taking off CO2, more we're putting oxygen onto, so the higher we're going to see our patient's oxygen saturation. And what else? Talk about other things we can change. So sweep, so sweep actually won't change, as long as there is sweep there, typically doesn't change your oxygenation, whether you go up on the sweep or come down on the sweep. But there's one part of the sweep we can control. What is it? FiO2, yeah. So the fraction of inspired oxygen. So like I said, most of our patients are on 100%, so we're not changing this that often. But if somebody wasn't, you can turn that up to 100%. Much like on the ventilator, right? We turn the FiO2 up to 100%. So blood flow is going through the ECMO circuit, and FiO2 determine oxygenation. What about for CO2?
That's the sweep.
That's the sweep. That's the sweep. So sweep, if we go up on the sweep, we clear more CO2 or retain more CO2? Clear, right? It's just like, so think about it like this. It's like the ventilator, right? The more we go up on a respiratory rate or the tidal volume, the more CO2 we blow off the patient. The same thing with the sweep. And actually look at the units, it's liters per minute. When we think about, if we had on the ventilator, we can think about minute ventilation. It's also in liters per minute. So if we go up on our minute ventilation on the ventilator, we clear more CO2. If we go up on our gas sweep gas rate of liters per minute, we clear more CO2. They're analogous. Okay. Now, interesting, you might say, well, why doesn't, like, when we go up on the sweep gas, why doesn't that change your oxygenation? It just has to do with the efficiency of the oxygenator. So if the oxygenator has a little bit of oxygen getting to it, that's enough for it. If giving it more, it's not going to make oxygenation better. If you turn it to 0, there's no oxygen going to the oxygenator, nothing's going to happen. But as long as it has something, it's going to oxygenate fine. All right, so what about on, so perfusion? So on VV ECMO, remember it doesn't provide any hemodynamic support. So going up on our blood flow is not going to help the blood pressure at all. VA ECMO, if we increase the flow, should help our blood pressure improve. So increase the blood flow.
So you said sometimes your A-line can be flat. So when you're saying to like increase the blood pressure, are you just looking at a map or?
Yeah, mainly the map.
Okay.
Yeah, mainly the map. So just kind of to summarize, for oxygenation, VV ECMO, we go up on our FiO2 on the sweep gas. We go up on our circuit blood flow rate. For CO2 clearance, we go up on our sweep gas flow rate. For VA ECMO, same thing. And then for hemodynamic support, VV ECMO, we don't have any hemodynamic support, and VA, we go up on our circuit blood flow rate. Any questions?
Yeah, when you guys are titrating, do you base it off of just a normal pH? Because I've had patients where their CO2 is 90 and we don't care as long as the pH is normal. Is that typically how it is here too?
That is a great question. I think there's been some practice variation in that, and like our thought process has probably changed some as we've gone through kind of iterations of patients that we've taken care of. It all comes down to the patient. One thing that I've thought a lot about and I think has helped some is trying to get our PCO2 level on the ABG a little bit more normal, potentially normal, in order to help try to wake people up so they don't have that drive to breathe. But it depends on the particular patient and how, what the chronicity of that PCO2 being so high.
There's also really unique situations, like, and I'm thinking about this because in a couple hours I'm going to give a lecture to the OB residents. So in pregnancy, there are some downsides to the CO2 actually being really high as far as fetal ventilation and fetal oxygenation. So, and our second patient we ever put on after our formal program was pregnant. I don't know if you guys remember that patient in September 2019, but yeah, there's definitely been variation. In general, like hard stop, you don't want really disastrous pHs. That kind of trumps the CO2, but we've fiddled with a lot of these things, just trying to get ventilator synchrony and really trying to awaken and mobilize patients, like Chris is saying.
Yeah, and maybe I'm biased, is I think we've had more success waking people up, getting them off paralytics when we drive their CO2 to a more normal range to get their pH to a little bit higher than where we had initially started off doing this. So kind of when we started in COVID, I think a lot of us looked at it as like, hey, we've got to get them on ECMO, we've got to get them off as soon as possible. So if we let their PCO2 be very high, but their pH is okay, then we can at least get them off ECMO and they can be on the ventilator. Whereas I think we've seen kind of more to try to make things as normal as possible, or somewhere in that range, and then kind of wean the ventilator, wake them up, get them moving. I don't know if you have other thoughts. But.
No, I agree.
All right. This is just analogous for the ventilator, just to drive it home. So on ECMO, we talk about our oxygenation, FO2, and our circuit flow rate. For CO2, we talk about sweep gas flow rate. For the ventilator, we can turn up our FO2, or we can increase our mean airway pressure. So often we go up on our PEEP to increase our oxygenation. And then minute ventilation is how we control our CO2 clearance, the respiratory rate times our tidal volume. Cool. All right, what about monitoring? So talk about the circuit. So you guys, this is, for those of you guys who manage the ECMO patients, is where you're really familiar with our nursing safety checklist. Emily and Chris, and forgetting who else has developed.
Me.
Yes. So this helps us to remember all these things. So for the circuit, right, we want to check our circuit connections, make sure they're tight, there's nothing loose. Make sure the cannulas are secured, so every time you're looking at the cannula, make sure those sutures are not been pulled out, that it's still firmly down there. Obviously, if there's any question, get the team involved to take a look at it. Presence of clots or air. So it's pretty common to see clots on the oxygenator. So if you guys look they start on the drainage side, the venous side, where you'll start to see some clots, and they look like on this cartoon here, they just look like little kind of dark specks. And as they get more and more clots, they kind of form bigger and bigger areas. When you start to see them, so that's pretty normal to see them on the drainage cannula side. When you start to see them on the post-oxygenator side, once the oxygenated blood's coming out, that's when you need to start thinking, okay, this oxygenator is getting pretty old and probably needs to be changed out. Because usually we won't see them there until it's more advanced. So patient, how do we monitor our patients? So oxygenation. So blood gas measurements, this is really important. So blood gas needs to be taken from the right upper extremity in patients on VA ECMO, particularly the ones on peripheral VA ECMO. So why is that? So think about where the cannula is coming. So it's coming up the femoral artery, it's going backwards up the aorta, and the heart's trying to pump out blood and compete against that. If you have lungs that aren't working well, then the blood that's coming out of your native heart that's coming out may not have very good oxygenation, versus the blood that's coming from ECMO is very good oxygenation. So where those two things meet, it may be beyond the blood vessels that are going to our brain and where we're perfusing our coronaries. So if we don't the best place to take the blood gas would be our right radial artery, because that's our furthest vessel from the ECMO circuit. So you're telling us where is everything mixing and what oxidation is the patient's brain and heart actually seeing. And the most accurate is from the right radial artery. And we'll have some slides to kind of demonstrate that if you're having trouble visualizing it in your brain. The same thing, pulse oximetry, we want to place it on the patient's right hand. So for hemodynamics, we want to, again, monitor our blood pressure in the right upper extremity if we can for patients on peripheral VA ECMO. And then we want to monitor our extremity perfusion digital cannula. We talked about pulses, which we may not have, but should have a mean arterial pressure by Doppler, and then tissue oximetry. So that's that foresight. All right. So this is just to kind of illustrate the concept why we want to monitor the right radial artery. So if we think about our cannula configuration on the far right hand of the screen, we have our drainage cannula and we have our VA return cannula going up the femoral artery and then going up the aorta back towards the heart. So if we have a patient who they have lung disease and heart disease, then all the blood that's going to their lungs is not being well oxygenated. And so if the heart is squeezing out poorly oxygenated blood and the ECMO circuit's putting in well oxygenated blood, there's going to be a point where those two things mix. And that could be really anywhere. It could be down, if the heart's pumping out a lot, then it could be down, very low down in the inferior vena cava. Or if the heart's not doing anything at all, it could be mixing all the way back at the aortic valve. But knowing where that's happening and knowing what's happening with the upper body is really important. So that's why we measure it on the right radial artery. Make sense to everyone? Okay. Shout out to the nursing checklist.
Please complete it, please do it.
Okay. With that, what could go wrong?
You can smile at the end of seeing gingerbread guys.
Yeah, it seems particularly cruel to terrorize a gingerbread man at Christmas time, at the holidays, but. Is it okay? All right, so what could go wrong? You have two really large cannulas draining blood, running at 5 liters a minute through a foreign body that generates an inflammatory reaction, induces coagulopathy, and then is returned to the patient. What could possibly go wrong? We should give credit. The gingerbread man was created by Dr. Knoll. So while I get to present this, fortunately, no humans were injured in this. Only gingerbread man is subject to harm. All right, so cases. So you cannulate a patient for VV ECMO for severe ARDS via the femoral vein cannulation configuration. The patient's intubated, paralyzed, sedated on 100% FiO2 and a PEEP of 10. ECMO is initiated and flows are excellent at 5 liters a minute. Vital signs prior to cannulation: he's afebrile, heart rate of 90, 120/80, respiratory rate of 20, and the pulse ox is 80%, not an uncommon scenario. However, after ECMO initiation, you can see the vitals are totally unchanged except the pulse ox increases a nominal amount to 82%. So what could be going on?
Did we put the FiO2 up?
So very good. So when we talk about oxygen to the circuit, one, we're flowing great, right? I think all of us would be thrilled to have flow of 5 liters a minute. So is there actually oxygen going into the membrane? So that's a great comment, and this has happened to us. Usually we're using wall mount oxygen unless we're traveling, where we can use tank oxygen. So did it come off the wall? Is it running? Is it turned on? I've actually been in the room, and I don't remember if it was me or someone else, we were stepping on the tubings. This is why you have to be careful, because you can sort of choke off and kink off the oxygen that's running into the membrane. So I can tell you that all that seems to be fine, and yet we're still not really responding to 5 liters of flow. So what else could be going on?
Would you say?
Cannula migrated?
So yeah, indirectly. So what could happen if the cannula is migrated? There's a word to describe this phenomenon that I can show you it on the next slide. Does anyone know what could be happening? So in general, and Dr. Knoll just talked about, one of our first moves would be, we're not oxygenating, turn up the flow, but in 5 liters a minute, we would expect that unless the patient had a very high body surface area, that should be adequate. So something that is unique to this femoral vein, well actually VV ECMO in general, I should say, not unique to femoral configuration, was something called recirculation. Have you heard this term? So essentially, you sort of develop these two parallel circulations. So what you want to be doing, this is your drainage cannula here on screen left with all these drainage ports. And that's sort of your rate limiting step. How much blood you can drain from a patient largely determines how well you can flow, which typically dictates our oxygen levels. In this case, it's paradoxical because we're flowing great and yet we're hypoxic. So what can happen is, she said migration, if this drainage cannula slides up closer to where you're returning here through the other femoral vein, you can suck back, and I like to describe it as stealing that oxygenated blood, and it's going straight back into the circuit. We're not trying to support the circuit with oxygenated blood, right? We're trying to support the patient. So the patient doesn't actually see the amount of blood that's recirculating and just getting sucked straight back into the ECMO circuit itself. So this can happen if this drainage cannula migrates closer, more cephalad towards the right atrium and stealing more blood, or if this starts to slide more distal and out of the right atrium. So the closer those get in proximity, the more at risk we are. And same with IJ. You know, when they start to come together, we start diuresing our patient or we turn them a lot. We monitor that cannula position because if you're just sucking blood right back into the ECMO circuit, the patient never sees that. So paradoxically, when this happens, increasing flow, do you think through the circuit, would this worsen it or improve oxygenation in the patient? Worsen it, because now you're sucking even more. The higher your extracorporeal, when you're recirculating, and this is a unique situation, the higher you go on flow, the worse you're going to oxygenate the patient, because now, relative to your native cardiac output, you're putting more flow just through the circuit, and that's redundant, and the patient's not seeing that. So that's sort of a unique situation. You can also, this can be exacerbated if the patient's cardiac output goes down. It's the same principle, that if more of that blood is being recirculated and going in the extracorporeal unit, the patient is not able to receive and then circulate that oxygenated blood. So how do we fix it? Get out the ultrasound and try to reposition under ultrasound. In the moment, actually going down on flow, you're going to recirculate less. And that's all just, again, this is a unique scenario where turning down the flow rate in the ECMO circuit will actually improve your oxygenation because you will steal less oxygenated blood from the patient.
Can you guys think about, like, if you're looking at the cannulas and looking at the tubing, what would be a clue that you're recirculating? Do you see the sats ever change?
The color.
So what are you going to see?
Darker blood.
They're the same.
So say
Is it darker?
They'd be the same and lighter because they're.
It's more red, right? Because the drainage cannula is stealing the oxygenated blood, so they actually become both bright red. Now the same color, that's pretty dramatic recirculation, so you can't look at your cannulas and be like, oh, there's a color difference, and use that as a sensitive test to rule out recirculation. And in fact, there are formulas you can actually figure out the fraction. But yeah, if you do see that color change not there, that's a problem, and you're probably recirculating. All right. More scenarios.
Can I just make a comment about
Yeah.
that? You know, I always have to have something to
Yeah.
say. We talked about this before because nurses, we like to mark things, right, on entry where it enters the body. But because of these cases, these people maybe are cannulated for a long time, so they lose weight or they're fluid overloaded, and we diurese them, and then the marking of the cannula isn't accurate. So, we talk about this, we did competency on this like 2 years ago, that you look for your color change in your catheters, right? You look for your flow, you look at your flow, you look at your SAT, and probably need to call for X-ray. So, emergent situation where you want to call your ECMO physician right away if you notice anything like that happening.
Yeah, and if you guys are ever concerned about the positions of the cannulas, X-ray is helpful, and we can also ultrasound and try to get an answer on that.
And just to contrast, like the color, we talked about both bright red, that would be an extreme case of recirculation. If they're both dark, venous looking, what does that mean? Yeah, you're not oxygenating.
Very good.
So we see that when we talk about recirculating a patient, where they're off, the sweep gas totally off, no oxygen going to it, or if there was a malfunction or the oxygen source was out, that would see both very dark blood. So it's a quick visual you want to look at when you go in the room. Okay, I see color change, dark venous to bright red. Okay, I know that oxygenation is happening.
All right, so another scenario. You're called to the bedside of a patient on VV ECMO due to the controller repeatedly alarming that the circuit has low flow. You've been diuresing the patient for the past day. Looking at the circuit, you observe that the lines of the circuit intermittently sway and shake, followed by very brief low flow alarms lasting a second or so that then resolve on their own. So what's going on? I'm going to show you guys a couple of videos. Oh no. It did work at home. Here, let me see. If I click on it. Definitely worked for
In the
me.
bottom left of the image, that shows a little.
Here?
Yeah, good.
It worked every time I did it at home. I don't know if it's a cool
line
button.
that shows up if you go to the bottom left
Here?
on the picture.
Yeah, I did that.
Right there.
Here?
Yeah, try right clicking it.
I don't know. It worked like every time. now all sorts of things are happening.
No, push the play on that one. Go for it.
This one?
Yeah. Look at that screen. I don't think you should look at it.
Oh, sorry. I can't see that on my little thing. It's really hard to direct. Why is it floating? I don't know what's going on. All of a sudden we're getting video kickback. Did I hit something?
Do you unmute yourself? Or you turn up your volume? Turn on your volume.
I don't know, guys. We've all seen this phenomenon, but I can't get it to play. I apologize. So, what's going on? Shattering. Chugging. Why? What'd you say? Low volume, so low intravascular volume. Good. What are some other reasons this might happen? What's going on?
The flows may be too high.
Yeah, so if we're asking more, the larger the cannula, the more flow we can have because there's less resistance. So if we have really high flows, we have high RPMs, a lot of negative pressure, and that can cause this effect, which, let's see if I can advance the slide. Here we go. This is a great pictorial representation of what goes on. So this is sort of simulating that vena cava. And if we think about a patient who's diuresed, now the walls, intravascular volume depletion, it's going to have a smaller caliber, smaller radius, and it kind of collapse in on those drainage ports that are under tremendous negative pressure, right? Something like negative 60 millimeters of mercury. We don't like these to get up to like negative 100 millimeters of mercury. And so that can actually suck down the vessel wall and have these brief periods of like no flow. We're not preloading the pump. There are these brief interrupted periods where we're actually not draining from the vena cava itself. And so that can cause then the lines to sort of chatter and chug. Patients that are more susceptible to this, the diuresed patient, the hemorrhaging patient, if you think about sort of the variation in size of the patients we put on, so not everyone has the same caliber veins. So we actually measure those when we think about cannula size. We've put some very small women on ECMO. I say women in general because they tend to have a smaller habitus. Their walls are going to be closer to these drainage ports that then can cause collapse. Now, if this gets severe and you're in a situation where it completely collapses down, that pump is still rotating at those RPMs, and it can actually create such negative pressure that something called cavitation can occur. Cavitation is when you actually can draw under such negative pressure gas out of solution. So we obviously have gas dissolved. That's what we're measuring on a blood gas, right? So you can pull oxygen and carbon dioxide out of solution and actually create little air emboli. So this can also damage red blood cells. It can cause hemolysis. So this can be a dangerous thing. And we also see it, I mean, I'm sure you guys sign out to each other and it's like, every time she coughs, she desaturates. Well, why does that happen? You're coughing, kind of bearing down, increasing intra-abdominal pressure. Now we're thinking about pressure around the vena cava is pushing in on it. And that can also have the same effect. So sort of collapsing the vein around the cannula and not adequately draining. So diuresis, hemorrhage, we talked about that. Why do you think sepsis can cause this phenomenon? So overall, if we're in a really vasodilated state, we're sort of increasing the size of the tank, but not the blood volume. And then also, there's a lot of capillary leak that goes on with sepsis. That's what drives ARDS in general. So you get a lot of loss of intravascular volume into the interstitium. So overall, that can actually cause hypovolemia as well. Focal compression around the drainage cannula. I remember we had one woman who had a retroperitoneal hematoma, and we did actually think that part of that was potentially affecting from external compression of the drainage cannula. And then thrombosis. I really like analogies. This one might totally ruin milkshakes for you. So my favorite kind of ice cream is cookies and cream. And if you've ever had like a cookies and cream milkshake, think about you're sucking, and then what happens if one of those cookie pieces gets into the straw? You're sucking down and your straw completely collapses, right? And it's totally occluded. And then if you suck hard enough, you might be able to suck that cookie piece and get your milkshake again. Similar thing, thrombosis. So if there's a clot inside the cannula that's going to increase resistance, you may be increasing RPMs, or even if you stay at the same RPMs, that can kind of cause that collapsing effect and affect flow through that cannula. malposition we kind of talked about, and then what Chris Fox brought up, if you've got really high flow and really high RPMs, that can create really an excessive negative pressure and cause these suck down events to happen. And that's where we might end up putting in a second drainage cannula. That's rarely been required, but we have had to do that. So anyone have any questions about the chattering, chugging? This is why a lot of our patients, have albumin at the bedside. I would say that if these are very transient occurrences and they're happening with coughing, really fluid loading a patient isn't necessarily going to help. But in general, increasing intravascular volume can kind of resolve some of these effects, as does turning down the flow, as long as their oxygenation can handle that. Question.
Just a quick question. With
Yeah.
like, the ECMO orders and everything, is there a PR in albumin?
There is. We've had that order in there.
To be included into it?
I don't know if it actually comes up in the meds, but we've functionally achieved that. Having it in the room.
Sorry, I think
A
there
nursing
is, but
order?
it says like must have approval of whomever. Like you have to like get
The approval.
like the
Yeah.
first. But I
Yeah.
think it is ordered.
I know that we've had that before.
And I think just to be clear, like if you have the event where this is happening and if they have suction event where flow stops, turn down your flow. That might release it and then you can just gradually come up. That's like the emergency situation. And then if you need to get volume, like we talk about albumin, it's no magic to albumin. It can be LR, be normal saline, it doesn't have to be albumin. So if you have other fluids in the room, it's fine.
Why
When you have
does
when you have your perfusionist at the bedside, a lot of times they can, it's faster for them just to run whatever crystalloid they have attached to the ECMO circuit through the circuit to help pop things
Why
up real
does turning down the RPMs? So remember that RPMs, you dial in RPMs, but you get the flow that the resistance allows, as Dr. Knoll says. So if your patient's dry or your patient's hemorrhaging, you may turn up your RPMs and not see an increase in flow. So why does turning down RPMs help these suction events?
Like releases the
Yeah.
vessel like releases it off.
Exactly. So you're turning down the RPMs, you're kind of lowering that suction pressure, that negative pressure. Good. So you are helping to turn an ECMO patient when the return cannula suddenly becomes dislodged from the patient. What do you do? In this scenario, having only encountered it in a similar way once myself, this is terrifying. And this is where I think about Dr. Puri's quote that he said, and maybe he read it somewhere, but before we started our program, that ECMO is 99% sheer boredom and 1% sheer terror. So this, without mincing our words, this is a sheer terror event. So what do you do? So clamps, love it. So the first thing you do is, and I'll sort of interject, we had a patient that had a similar scenario to this, and I'll kind of intersperse parts of how that was handled. So the first thing you do is absolutely clamp is the answer, call for help. So I will never forget on a Saturday morning, rounding on bed 20, talking about probably tube feeds or something, when someone came out into the hallway and saying, we need help down here, in a way that it was like very clear we had to run. And getting into the room, there was blood all over the walls. There was blood spurting out from the neck area and the end of the cannula. So let's go back to this case, and then I'll tell you what happened in that case. So here, the return cannula is totally dislodged. So if we're flowing at 5 liters a minute, 5 liters a minute is dumping out onto the floor or the ceiling from that cannula. So the right answer is clamp. What if you're the first one in the room and you're like, I don't even know where the clamps are. What's the quickest way you can clamp up? Exactly. So you can just kink. Robbie always likes to show us how to do that. So kink off that return cannula so you stop exsanguinating from that return cannula. Also think about the groin in this scenario, that groin is also going to have bleeding. So someone else can be holding pressure there. So assuming you do have clamps, I love the Dr. Knowles. You draw all this stuff out, right? So we're clamped off. So now we're going to come off. We're going to turn the pump off, and we're going to come off ECMO. So if we're on VV, what else is going to start happening to the patient if they were circuit dependent? They're going to start desaturating. So if respiratory is in the room or someone else can help you, go on what we call emergency vent settings. Maybe we had become very lung protective, turn up the tidal volume, turn up the FO2 to 100%, go up a little bit on the PEEP, because now you're relying on this patient's native lungs to oxygenate. So we've called for help, we've clamped off, we've turned off the pump, and in the scenario, let me go back to the actual scenario that happened to our patient. So of the two potential possibilities, either that return cannula was going to be totally out, or in what actually happened, the tubing had popped off. The patient had been turned, there was probably a little bit of a tug, and it popped off. So we were bleeding from the cannula, which fortunately was still sutured in and was in perfect position. So the nurse was appropriately applying broad pressure to the neck, but what really then we moved to, and forever since that day I've referred to John as the ECMO ninja. John had this patient clamped off ECMO, so clamp, and the power turned off, in seconds. And then if you clamp or at least finger cap, in this case I just put my thumb over the end of it, so we stopped losing blood additionally from this site. So now you've stopped the blood loss. Since the cannula is not out, you want to go back on ECMO, but you need an airless connection. So how could you do that? Well, again, ECMO Ninja John, because it's the return cannula and it's under positive pressure, he unclamped the return cannula so it was bleeding back, and then we were able to establish an airless connection, go back on pump. But now, what might happen to this patient that's just lost all this blood and had very severe hypoxia? So he went into PA arrest, and we'll kind of talk about what to do with cardiac arrest on ECMO. But calling for blood in this case, we didn't have to MTPM. He got 2 or 3 units. Responded to that. We were able to get ROSC, and I'll save. We're going to talk about a cardiac arrest scenario shortly. So I think the things to take away from this are call for help, clamp off. If you're totally decannulated, then someone needs to recannulate this patient, which is going to take some time. So call Dr. Knoll if that's the case, because that's going to take some more time. Anything else you want to say about that case?
I would just say, the friction connections that you get when you put somebody on, initially, they are tight. But, in this particular situation, he was on ECMO for 60 days or something like that before he popped off.
Yeah.
So over time, with the heat and everything else, the tubing becomes more pliable, and they're easy to slip off. So you'll see that they put these little, sort of zip ties to help maintain that friction connection.
So that's a really good point. Actually, I meant to say this because as a result of this is where 2 things came out of this. One, we had debriefing in the moment because this was really, traumatizing for everyone involved. I called his wife, told her what happened, and so we have sort of an ECMO debriefings protocol that happens where we debrief with the staff. Then we actually then discuss it at our next ECMO meeting, and this is where the checklist came from. Because I think that while the answer to the question is clamp, come off ECMO, the real answer is preventing this from ever happening. And that's what diligent sort of visual inspection, tactile inspection of all these connections does. Every connection, every shift, every day, it becomes very mundane, but if it prevents this in any patient, it's worth it. So this is where our checklist came from. All right, so you're at the bedside rounding on your patient on VV ECMO. The patient and the circuit are doing fine. Suddenly you note a large amount of air in the circuit. What do you do? Go to lunch. So before we, oh yeah, go ahead.
I just had a quick question.
Yeah.
What if the venous cannula came out and then sucking air through the...
Exactly. So if the cannula's out, you're let me think about that. So you would essentially be holding pressure from that. You would still have to clamp off the arterial and come off ECMO and recannulate. But you're right, if it's sort of partially dislodged, you can entrain a ton of air. Like if part of the tubing is and you're entraining air, that is the negative pressure side of the circuit. So yeah, that you may have to clamp off, and that's actually relevant to this scenario. Do you want to say anything else about that?
Yeah, that's the scenario.
Yeah, that's the scenario. For Mr. Gingerbread Man. So you're noting a large amount of air in the circuit, so that's actually the question I was about to ask. So where can this air come from? So she brought up it can come from that, right? It can cause from the cannula being dislodged or cracked, some sort of loss of integrity. Where else?
Cracking or oxygenated?
Yeah, anywhere in the circuit, a breach. But think about something you guys, especially you at the bedside, manipulate every day, not even related to the circuit. Central lines, so venous ports left open, that can actually introduce a lot of air into the patient. or the circuit, so something to consider. So what do we do? Yeah, exactly. Call for help. If you think of nothing else, call for help. But yes, exactly. So this scenario, so there's kind of, I hate to call them good bubbles, but there's kind of good bubbles and bad bubbles. So if you had very small micro gas emboli on the venous side of the circuit, so your cannula is intact, and maybe there was a port that was a little loose, or you had a lot of negative suction events, and maybe you had some cavitation, so there's a little bit of gas on the venous side, that can meet the oxygenator prior to the patient. And you've probably seen Robbie do this, or some of the perfusionists do this. There's a little vent, and you can actually de-air or sigh the circuit, and you can release gas from the oxygenator. So in that scenario, you may not have to do a lot of stuff and replace your circuit. What we're talking about, and I think it's up there now, kind of massive air emboli on the return side. And that's a much more dangerous situation because all of those air bubbles are going to go back to the venous circulation of the patient and in their right heart. And while their lungs may be able to absorb some embolism from the air, you can actually really increase the afterload on the right heart and cause cardiovascular collapse. So these can be really dangerous. The other thing is, even if it's on the venous side, if you entrain a large amount of air, it can actually kind of dislodge the pump head and create what's called an airlock and prevent the pump from doing its job. So let's get back to this scenario. So you've got a large amount of air here. We've called for help. We've clamped off. And in some circumstances where it's not a catastrophic amount of air, or you know exactly where the air came from and you've now sealed that off, you can try to aspirate on maybe the venous side or the drainage side of the circuit. But if you have a ton of air like this, clamping off and then probably needing to do a circuit change would be indicated with this much air. Any other thoughts you had? And I just put a picture of exactly the scenario you described. You want a clamp pretty proximal. This is most likely the venous drain. I took this from the internet, but given how dark the blood is, this is a massive amount of air. This would be enough to disengage that pump head and create some problems with the circuit.
Can you just go back to this slide?
Yeah.
So one thing you mentioned, like the venous, like air going to, this was VV ECMO, air going to the lungs, but if you're on VA, think about like causing a stroke,
Exactly.
things like that, so much more catastrophic for a bubble. The other thing is, if you have an event like this, where is the negative pressure portion of the circuit?
On the drainage side.
The drainage side up until where?
Up until the other side of the pump, right?
Correct.
That's the pump, correct. So here to here is going to be under negative pressure, right? Because this is spinning, it's pulling blood this way. So if you have a bunch of air in the circuit, you're going to clamp off, run your circuit, but your eyes should start at this section here. Because that's where if you poke a hole in here, where there's an opening connection, air is going to get sucked in. If you poke a hole anywhere here, it's going to squirt out.
Blood loss. Even if it's a small port, you're going to have a significant amount of blood loss. Yeah. Or at least it's under positive pressure. Awesome. So, yeah, I think the takeaways here are, absolutely VA ECMO. This is catastrophic air on the return side. Large amounts of air on the venous side or on VV ECMO are also catastrophic. So probably don't waste time aspirating. You need to clamp off and most likely do a circuit change. Yeah, go ahead.
Also not sure if this question is valid, but since I've never seen air go through the circuit, how quickly?
Seconds.
Yeah,
Think about like
liters per minute. Yeah.
Retention for air, you can take liters of air in a matter of seconds on the drainage side.
That leads me to my second question. I'm so sorry. Would clamping be faster, or would you turn down flow first?
You could do that too. I mean, it would move slower, but both. This is where all hands on deck sort of scenario.
Clamps always work the best.
Yeah.
And that's the same thing that Emily touched on. These are your best clamps. Just clamp off. Whenever in doubt, clamp off and scream for help, and somebody will come running.
I was going to say in relationship to that, now you have to figure out where your air came from, because if you do have a central line issue, before you recannulate or put them back on ECMO, you need to find your cause of the air.
Well, exactly, and you may not have fixed it. If you exchange the whole circuit, you're likely to have, but yeah, that's a good point. When you're running your circuit, it includes the patient, the cannulas, all the way around, because the air can be entrained anywhere.
But at the bedside, if like the patient needs a central line or the dialysis catheter, you guys advocate, make sure we're positioning the patient appropriately to prevent air embolism. So putting them in for doing the IJ, putting them in Trendelenburg, so we're doing the femoral, making sure that the feet are down.
And clamping off reports that aren't used.
Right.
There's actually case reports of large air emboli, even just with central line insertions, so being kind of disastrous. All right, so this is the scenario, and this was actually part of our bleeding scenario too, but you're rounding on your patient who's day 3 on VV ECMO. Suddenly the patient goes into VFib. What do you do? So VV ECMO.
CLS.
Very good, right? So as we talked about earlier, you're not getting any circulatory support from VV ECMO. Now, should you keep your flow going? Probably, because you still want to oxygenate the blood. So you would absolutely do CPR, call for help. Do CPR, run your ACLS, so you're still going to want to defibrillate this patient. You want to get them out of VFib, give amiodarone, do all of the things you normally would. With respect to the circuit flow itself, you might have some issue with just doing you would absolutely do chest compressions, but that increased pressure can be transmitted to the abdomen. It might affect your ability to keep your flow at the same level it is. So you might have to sort of turn down flow in like 500 increments in order to not have loss of pressure just from the chest compressions themselves. But you need to perfuse, and you want to oxygenate your blood too. This would be another time, turn up the ventilator at 100%. You want to make sure you're oxygenating your blood, but in order to perfuse, you have to do CPR. And I think that, and then just think about the cause, right? So why is this patient in VFib? Think about your H's and T's. Do they suddenly have a pneumothorax? Do they have cardiac tamponade? Is this an electrolyte event? Think about what the cause is. Think about air embolism, look at your circuit. So what about same scenario, but now your patient's on VA ECMO? No, so you're dictating perfusion with the circuit. So you absolutely still treat the arrhythmia. So you want to defibrillate, you want to give antiarrhythmics, but you can actually dictate with your flow that your perfusion. And so here, like we talked about, if the heart's fibrillating, are you going to see a pulsatile A line? Probably not. So that's where you can kind of, you might have to titrate your inotropes and vasopressors as well, because now there's no native cardiac ejection. So look at your mean arterial pressure and titrate your flow to that while you're expeditiously treating the arrhythmia, and also thinking about what are the causes of VFib on this patient. If they have other support devices, was there any migration of devices? What's the body temperature is another thing to think about. What are the electrolytes? All those things are relevant when you're trying to figure out the cause. But this is a scenario where you don't do CPR, you have circulatory support, so just dial your RPMs to increase your flow in order to get an adequate mean arterial pressure. All right, so I think this is the last scenario. You're called to the bedside for low ECMO flow alarms. As you enter the room, you notice the flows are 2 liters per minute versus previously being at 5. The patient is day 30 on VV ECMO for COVID ARDS, and think about the unique aspects of COVID and how could that contribute to low flow. And you see and hear the following. Oh, so this better work. So you guys hear that? Yeah. It's terrifying, right? I don't know what it is about me being on. Chris was on too was this the actual or was this a sim event?
That was a different one.
Okay.
No, that was an actual one.
That was an actual one. So this has happened at least twice. So what's that noise? What's happening? Very good. So why would COVID be relevant? We saw it more than once, and actually the patient that we encountered was a COVID patient, and what we think is there was a thrombus inside the cannula that then got transmitted to the pump, and those pumps are rotary pumps, and a thrombus, an airlock, anything can sort of disengage that pump, and so it started making that rattling noise. So what do? Circuit change. Yeah, so call for help. Reiterate that. Clamp off the circuit. In this scenario, and I forget if we did this because that's a blur, but did we try to go on hand crank? Because there is actually a backup pump, which technically if you disengage one pump, but you're still with the same pump head, so I guess that wouldn't, yeah, you still have the clot. So say you had loss of power or your battery died. You could, if you didn't have a huge thrombus in the pump, you can actually, with perfusion's help, you can transfer that pump head and now hand crank while you're preparing to do a circuit change. But yeah, I wasn't thinking through, you still have that thrombus. So in this case, you're clamping off and you have to do a circuit change. All the while, again, your patient is now dependent on their very sick lungs, so turn up the ventilator settings and try to oxygenate without the help of the circuit.
If you hear a strange noise, and if you look at the video, see that white ring around the middle? That's what like the clock might look like. It's kind of it's center of it, you hear the noise. So think about, like, you shouldn't hear that, so think about a clock.
So we like to really just sum things up with systematic approaches in general. So just common scenarios. So, or Mr. Gingerbread Man is hypoxic. So think about the patient, the ventilator, and the circuit, and any malfunction can happen in any of these. So are the flows adequate? So, we learn with the physiology, what knob do I turn? If we have a hypoxic patient, one of our first moves is to increase the RPMs, and are we getting adequate flow? If we're not getting an adequate flow, we'll actually talk about that on the next slide. Is there a color change? So look at your patient's color, but also the drainage and return lines to see, is your oxygenator doing what it's supposed to? Is there recirculation? Think through that. Has anything changed with the ventilator? Did the patient all of a sudden have atelectasis or a pneumothorax, and maybe that's contributing? And think about the relative cardiac output. So again, if you're, so in general, say, throw away recirculation for a moment. In general, the higher the flow you run through the circuit, you're better going to oxygenate. I think we understand that. If the patient, and think about the septic patient, say we're running 5 liters a minute through the circuit, and the patient's cardiac output is 5 liters a minute, we could probably easily oxygenate that patient. Let's take now a septic patient. Let's say now that the cardiac output is 10 liters a minute. Now, proportionally, we're only seeing about half their able to oxygenate half their cardiac output in the circuit. So there are scenarios, you've probably seen us do this, heart rate's really high, they're febrile. We sometimes will give a beta blocker to lower the native cardiac output so that more of it is captured with the circuit and oxygenated with the circuit. And then the recirculation issue also comes up as being a separate issue, where that's more of an issue itself with position and just sucking back that oxygenated blood that we're trying to infuse into the patient. So low flow, think about what can cause that. Is the pump on? Do you have power? What are your RPMs? And is there something increasing the resistance? So if you've got high RPMs, but yet you're still not having flow, there's got to be obstruction somewhere. So is it a clot within the cannula or the tubing? Do we think there is sort of external compression, either from suck down events or thrombus in the patient's abdomen or even thrombus within the cannula? All of these can increase resistance of the circuit and lower the flow. As can high intrathoracic pressures. So pneumothorax, those things can actually make it, can create low flow. And then in the VA situation with VA ECMO, if your native, we kind of talked about this, if your native contractility is kind of coming back and you're pumping, again, that the ECMO is going retrograde, now it's actually can interfere with ECMO circuit flow. So recognize when it might just be that the LV function is recovering and now competing with the return flow of the circuit. And then, this is a very formal way of saying unplanned cessation of ECMO. That oh shoot moment of decannulation, partial decannulation, or tubing popping off, or the pump head getting disengaged, or the power going out. You can see a lot of different things can cause this, but in general, maybe there's a massive air embolus, maybe there's a clot, clamping off, relying on, if we're in VV, turning up the ventilator to emergency settings. If we're in VA, adjusting vasopressors and inotropes upward, and then trying to treat the underlying cause. And if nothing else can improve it, then we may have to switch out the circuit. So I think these are some summary points. Do you want to touch on these? I have just like one very short slide after the next one.
Sure. I think we talked about all this. So really, ECMO's for temporary cardiac and respiratory support. We use it as a bridge to something, whether that be recovery, transplant, or some sort of treatment, or time to make a decision about what we do next. A lot of different cannula configurations. We talked about some, but as you guys will see, it becomes increasingly more complex. We're all learning about it. Think about where the blood flow is going, where is the native cardiac output coming out, and how might those interact with each other. So drawing it out, I think is helpful. And then we talked about how we determine our oxygenation circuit blood flow rate. We're FiO2, we clear CO2 with our sweep gas. We improve hemodynamics with our blood flow on VA ECMO. VV doesn't provide that support. Remember, we're going to put our arterial lines preferentially in the right upper extremity, particularly the radial artery is the preferential for particularly peripheral VA ECMO. And then we want to monitor our perfusion distal to the cannula, so particularly in the legs. We're going to use our foresight tissue oximetry. We want to monitor kind of our normal neurovascular status, but you may not actually have a pulse. And obviously discussion with the team and things if that's like expected or not is always helpful. And then we talked about LV venting, so that the LV, because it's weak and not contracting well and we're competing with the ECMO circuit, it can get distended and clot off. So ways we can empty it would be through balloon pump or Impella. And then we talked about a systematic approach to troubleshooting.
So quickie quiz, our patient in 5 who was on VA ECMO for cardiogenic shock, draining from femoral, returning to right axillary. Now where do you want to monitor from?
Would you still do your right radial?
You probably could. I actually even pulled papers on this. Really though, the most distal site would be left radial, and is what the paper said, because technically you're kind of flowing towards this hand, although you're kind of relying on, you're flowing this way and you're relying on it this way.
Yeah, I think that one gets really tricky.
I think we did left radial.
No, we looked at both.
There was actually a table in a paper I pulled, and it had every cannulation configuration, and for right axillary it said to do left radial. But so this again, Dr. Knoll found this book. I think if you're looking for sort of a concise resource that's not written in like flowery technical language, it's just kind of straight to the point, very easy to understand, and really something you can digest. And it's not an encyclopedia; it's more of a handbook. It's really good. Yeah.
I can order that too. I can get a couple copies of it.
Yeah, that'd be awesome.
If anybody wants to borrow it,
And
sign it out.
maybe I was feeling philosophical. I hadn't really read it, and so I read it. Chris had always recommended it. But I actually think these last couple points bring up a lot of, and these are actually sort of quotable from this book. ECMO is really hard, and I think that it's hard on us as practitioners because these are very sick patients and they have variable outcomes, and I think sometimes we sort of blame ourselves and our technique, but ECMO is not a miracle machine, and it can't reverse the irreversible. Now, the challenge is that it's hard to predict who truly is reversible and who's not, and I think that a lot of these scenarios we talked through, and something that I've always said, I think the hardest decisions in ECMO are who to put on and when to come off, like when to call it quits. Not when they're actually weaning and doing well, that's rather obvious, but who to put on, when to go on, and when to come off in sort of a palliative fashion. And I think that this book kind of points out that, you're always going to wonder if the timing is right. There's like no absolute, and if there's things that we lose sleep, I'm sure you guys lose sleep over this, is like who to put on. And the problem is that there's nothing that predicts with absolute certainty that someone's going to recover and not. And obviously there are a lot of untoward complications. But just for you guys to know, because it probably, especially during COVID, and there are a lot of our cases seem sort of haphazard, like why does this person go on and this person doesn't? There are so many things that we talk about, and I can't even think of a patient we cannulated where it was a one-person decision. It never is. In fact, always we have a conference call, and there's often 10 people on the phone giving their opinion and talking through all the nuance of that particular patient. And most programs do it this way, that it's decision by a large, because you sort of feel like you're deciding who survives and who doesn't. And I think we have less control than we often like to think we have, but these are always multiple provider decisions, and we think a lot about these. But if you ever wonder, why didn't this patient go on, just ask, because certainly it's hard to always know what the right call is and who to put on. So with that, I think we've got some hands-on stuff. There's a number of other resources, but we're happy to take questions.
Is there a certain time that they have to be on where you do a circuit change, or does it just happen to be certain scenarios that you brought up where it's time to do a circuit change? Because I've never had a patient.
Get a circuit change? So with VV patients, it's usually a little easier. You can actually draw blood gas from post-oxygenator, so you'd expect that to have a really high PaO2, right, like 300, 400, and if you're seeing levels less than 150, so we can sort of, usually with VV, unless there's a sudden thrombosis event, you creep towards needing a circuit change, and we have more kind of leeway in that decision. But for these catastrophic events where clots are flying and air is flowing, those are just in the moment, kind of with the conditions we described. But for many patients, we can anticipate the need based on how good that blood gas is coming out of the oxygenator. I don't know if that answers your question. Okay. Yeah.
And when that happens is very variable based on the patient. We
Yeah.
have patients who they're fine for weeks on the same circuit, and no clots, nothing. And then other patients every 2 days, the circuit's not working again.
COVID in particular, we got a lot of clots in them. We haven't had a lot of circuit changes with VA, have we?
No.
Yeah.
Obviously, that changing
The
VA
shorter runs.
is always a little
Yeah.
bit more. You would probably wait until you absolutely have to, because there's more risk with a circuit change on VA than on VV, with the possibility of introducing air. And then unexplained, even when the circuit's working, unexplained hemolysis is another reason why we might, even if the membrane's working, we may elect to change the circuit.
Move a change at the bedside versus go to the OR.
Yeah.
Right.
Yeah, all circuit changes will be done at the bedside. Some cannulas might be done or removed at the OR.
Most of even our repositioning of VV cannulas is just bedside too. The VA stuff tends to happen more in the OR.
I have 2 questions. Can you talk a little bit about VAV ECMO and the role of Electri, and is there a benefit in it?
Yeah, so I guess we'll tackle that first. So we kind of think about inhaled epoprostenol or Veletri a lot of times in patients either with right heart failure or if they have bad ARDS. So even before ECMO, we sometimes employ Veletri to improve oxygenation. Now, sometimes it buys you an increase in SAT for a little bit, yet you're still failing, and it can just kind of delay the inevitable and make the timing more emergent, and so sometimes we don't turn to that, but we do use it in patients with right heart failure. If you think about the right heart and these very hypoxemic ARDS patients, their pulmonary vasculature is very vasoconstricted, and that puts a lot of load on the right heart that our right heart's not used to seeing. And then as Dr. Knoll talked about, we're dumping all this flow for VV into the right heart, and so over time the right heart can fail, even if you just cannulated initially for hypoxic respiratory failure. And so that's where we have, in a couple scenarios, have used VAV, where rather than just you're kind of splitting that return, so you're still draining from a vein, but you're returning part to the artery and part to the venous system. So you're both hemodynamically supporting the RV and kind of lessening that afterload, because you're returning part of the flow to the arterial circulation. So it's a way to sort of hemodynamically support the RV, which I think we've only done 2 or 3 times maybe. I don't know if you have more to say about VAV.
Yeah, so VAV, for those unfamiliar, right? So we have one drainage. We're draining from the venous side, and we're putting oxygen blood back into the venous side and the arterial side. So there's 2 scenarios where you can think about that. One is patient, like Dr. Davis was saying, who's on VV, and now they have cardiac dysfunction, whether they're the right heart or the left heart. So now you're adding arterial return to help provide hemodynamic support. The other scenario is you're already on VA ECMO, but you're having trouble oxygenating the patient because now their lungs are bad. And so put in another return cannula into the venous side, so you're both returning blood, venous and arterial. The configuration's the same, but the reason why you might start it may be slightly different. Make sense?
Yeah. She had another question?
I asked about the role of Electra in.
Oh, yeah.
Did you answer it? Yeah. One more question about VAD. So when say you're on VV ECMO and you add the arterial cannula because you're in cardiogenic shock or something's going on, what will you see in the patient to know that you now no longer need VA and you can convert back to VV?
Oh, to remove that return? Yeah, sort of improvement in right heart function. So you're kind of coming off inotropic and vasopressor support, very similar to when someone's on VA, looking at their heart under echo. It was actually pretty hard to tell in one of our patients who went on, he ultimately got transplanted for COVID.
I'm thinking about the guy that was in 26.
Yeah, you can start to wean flow. So because you're splitting, you're kind of picking, you can use clamps to return more to venous or more to arterial. So as you're reducing your arterial flow and the patient's hemodynamically tolerating it, you can actually do echo assessments while you're doing that. You start to see, well, hey, we're lowering that arterial support, that right heart support, and he's tolerating. But to some extent, because you can't totally just clamp off an arterial cannula because you'll thrombose or cause a stroke, it's a little bit of a leap of faith even when you do those ramp trials with an echo. You don't ever know, I don't know for certainty that you could successfully come off.
Yeah, no, it was just his daily serial echoes and then reducing flows to what you would consider minimal flow while still being safe without thrombosing the cannula, and then
Like
coming
two,
off. Yep.
2 liters, 1.5 liters, but we don't really want to run it that way for a long time because you can thrombose and then cause strokes and complications. But in a pinch, in a ramp protocol where you ramp down that arterial flow, you can go down to 1 liter briefly, but not very long.
For the eCPR, we talked about it being for out of hospital arrest with less than 30-minute downtime, but could we do that? Like, is that something we are going to start doing? And then my next question is, could we also do it for like out of unit, like hospital-wide arrests?
Yeah, so you can. I'm trying to think how many patients we've done eCPR on. That young boy who was hit by a bus or a truck or something in the operating room, he got eCPR. There was a patient years ago who was severely hypothermic. His temp was like 80 degrees. He just overdosed outside. He
woke up angry.
Oh my gosh, he had an hour of CPR and then he woke up and was mad. But he survived. There were other eCPR cases we've had.
There was a patient that, that Haney and Mike put on, coach.
They talk about the role of Lucas with that. We started doing that during COVID to use the Lucas so that they could cannulate the patient for VA ECMO.
I think the challenge is the availability. Some of our providers have the skill set to arterial cannulate. Many of us are not super comfortable with that, and that's sort of historically at Cooper and almost everywhere in the country something a surgeon does. So I think some of the challenges is that available, and that's you need to get on in a certain amount of time to make it viable, and if someone's coming from home, night, weekends, it becomes harder to have that as an available resource all the time. Because it's a very complex skill set is the way I would describe it.
But yeah, I think the goal would be to hospital-wide in hospital and out of hospital. I think the staffing in that part is really the main barrier right now, how we would do that and make it a viable program.
And availability of perfusion.
Yep.
Yeah.
Is there any like different criteria or contraindication when we're talking about like recannulating somebody who's recently been decannulated?
It's a really, really good question. And I think the short answer is it comes all the way back to what you talked about, that like, do you think it's reversible? Because almost always in that scenario, your vent days are probably higher, and whether it's VV or VA. And we probably should look at the literature on that in our next meeting. VA, I think recannulations in general don't have great outcomes. Some VV patients do. Really complex situations. But again, if it's like a new, different insult that you think the patient can recover from, then I don't know if you guys have any other thoughts on that. It's a little bit of a bag of worms, I think.
Because is there just talking about like the vasculature that you're cannulating, is that typically more dangerous to
I don't think that's as much of a barrier, and particularly with VV, we've got lots of choices.
I mean, I think if you look at the risks of cannulation complications, they certainly go up for recannulation or additional cannulation.
Thrombus is a big impediment.
But certainly
Yeah.
you talk about it all the time. The number of our VV patients who end up with DVTs post cannulation. I mean, you can see that across the literature. I think as high as like almost 2/3.
Yeah.
So then sometimes you have to pick a different cannulation strategy, and it really comes down to the patient. It certainly can be riskier.
And then the VA, like the central VA stuff, is a whole different beast than outside of our scope.
Yeah, we would never be centrally cannulated, let's be clear.
Right. I don't put anything past you guys, but I'm out.
So I know that we have perfusionists and that we're trying to work towards getting more perfusion on board, and as our program's growing, are we ever thinking of getting ECMO specialists at the hospital as well, or would we focus first on perfusion staff? Just because I don't know if we ever have enough patients to even be able to have a specialist near bedside.
So ECMO specialist is a very broad term. And in some places, like the University of Michigan, where ECMO a little bit originated, some of their ECMO specialists are respiratory therapists trained, nursing trained. That term itself doesn't dictate the underlying training background of the practitioner. So here I would say we have a sort of varied background of ECMO specialists. Our perfusionists certainly. We are spoiled here. The fact that they're board certified in perfusion, for that part of the ELSA application, we blew that out of the water because of the skill level of our perfusionists. So the fact that New Jersey sort of mandates that, we are blessed to have their expertise. And I think that everything that we as nurses and physicians bring is kind of icing on top. But I think any training background, whether it's perfusionist, nurse, respiratory therapist, physician, can sort of be an ECMO specialist. It's a pretty broad term, actually, and depending on where you are and what the regulations are, the people sitting pump or really monitoring the pump might have different training backgrounds.
Yeah, I think I might just be confused.
Yeah.
Where I came from, there would be a nurse at bedside, but there would also be a specialist, or like they'd say ECMO specialist.
Were those physicians or an RN? Yeah. Yeah, so it just.
Trained on
ECMO
specifically.
Yeah.
So I just was
we would, love to expand, and that's partly why we're doing this.
Yeah, and just some of the reason why perfusion is always available is really state mandated, as opposed to, I don't know if you trained to be a BA from a different state.
Yeah, we have to have them in-house.
Okay.
That's the law.
I think we all learn from them, and I don't know, personally, great.
Great.
Like, we were definitely past that part of the application for ELSA.
But, Robbie does live in the hospital.
Yeah. The definition at Cooper is Robbie.
So no, Jason, the reason we're doing this, I mean, you guys ECMO specialists, right? You're here, you're learning about it. You're taking care of these patients every day. It's pretty cool.
Awesome.
Are we coming on?
Yeah, and then we'll let them shake it out and stand up, and then we'll set up the other thing. Any other questions?
I know that we had some issues a couple times with patients on, from my experience, VV ECMO, with sedation being very difficult to manage because of, I guess, the ECMO pump eating the medication. So can you talk a little bit about why that happens, and then, like on VA ECMO or whatever, does that also, do you have those similar problems with vasopressors, inotropes, stuff like that?
Yeah, it's a really good question, and we'd be best served to have Lauren Igneri answering this question. But because the pump, some certain drugs like lipophilic drugs, propofol, are significantly absorbed by the pump, and on top of that, these are such long runs that the patient sort of becomes tolerant, just like any patient needs higher dose to achieve the same effect. So that's certainly a challenge for our patients. I think overall our approach has evolved where we, as soon as we're able, we like to lessen all that stuff and get them off paralytics, off sedation, and kind of awake and participating. And we've all seen that sometimes that isn't possible just because of hypoxia. But yeah, I'm not aware to the extent that catecholamines and other drugs are absorbed by the pump. I mean, you kind of just have to ratchet up the doses to maybe achieve the same effect, but I don't know that those in particular are absorbed by the circuit. And a lot of that literature is evolving. Like we don't really figured out what are the best drugs and how much is absorbed, and there's complex pharmacology on that, and we talk about it, and I think only our pharmacists really understand that to the degree. But yeah, that is one of the reasons why you might see way higher doses than you would expect. But a lot of that too is just duration of exposure, and becoming sort of, tolerant. Tachyphylactic, I think, is technically the word.
Yeah, I think a lot of the studies, like, they measure, like, they hook up the circuit with actual blood and, like, put the drug in and then see, like, how much they're able to collect back, which, like, doesn't take into account, like, what does the patient respond to that level of drug and how sensitive are they, and so it's, like, really about, like, how's the patient doing, so.
Yeah.
But one of the things you may see, we often go to Dilaudid over fentanyl, and some of that literature suggests that it's more predictable in its effect and its level and its duration of effect over the long period. So you may see that as we switch from fentanyl to Dilaudid as they go on.
Yeah, it's a good question. I think an area of poor understanding at every ECMO center, honestly. Antibiotics, you think about a lot of the drugs we give, like we probably don't always know how much is being absorbed.
Yeah, and the change in the volume of distribution within the patient, everything changes, pharmacokinetics and change. But yeah, and that's why, if you ask a lot of ECMO centers, their answer to you is we just get them off as soon as possible. That's their best answer. Wake them up as quickly as you can.
Who wants to volunteer?
That's brilliant.
Yeah.
Sorry, guys.
So you guys, our workhorse in the ICU is the Rotoflow. It's a pretty older ECMO circuit, but it's very simple and it's very, somewhat intuitive in a lot of the ways that you can look at the components and how it's working. Some of the fancier ones that you may see at other institutions or you may see over the next couple of years as we get here have more sensors, they have more functionality that kind of more automate some things. So this is kind of a very mechanical, we can work through different issues with it just by looking at it. So let's start off with, we have a patient, Mr. Bagel, who's on ECMO. The circuit is just turned off, so we're trying to turn it on and get everything going. So this is a real thing, right? If it turns off, it's not that simple just to push the button and it turns on. So going through that is helpful since we've been using this machine here at Cooper.
There's no switch in the back, or is it this switch?
So that's true. There is a switch back there. That one usually is going to be that needs to be on, but there's a switch right here in the front. So it's covered by a little thing so people don't accidentally hit it. All right. You turned it on. So this is a nuance of this thing and why it's not that user friendly. So it says valve. What you need to do is you need to hit the silence button.
You want me to hit it again?
Yeah, just hit, and hit the valve button. And then hit silence one more time. So basically the sequence is turn it on. It's gonna alarm and say valve. Hit valve and hit silence. Once you've done that, then you can actually get it to start working. It's important because it doesn't make any sense, okay? Really. So power on, hit valve, hit silence. But once you're there, you should be ready to go. But the next thing you have to do is much like your high school locker, you have to turn this back to 0 first. Okay, so now you see that it said 0. So what I mean by that is if it was sitting here and you're not seeing anything, you actually have to turn it back to 0. So you push in, turn it back to 0 until you see 0 RPMs here. So now it's alarming because the flow is low. That's why it's beeping again. So it's actually detecting, hey, the flow is, I'm not seeing any flow, so I'm gonna beep. And we're gonna hit silence again. But, so now we can start turning up our RPMs. You can read out, what are your RPMs now?
1157, 1286, 1353.
Okay. What's happening with your flow? So
No flow.
no flow, okay. So this is another thing that we'll point out with this machine that you guys may have encountered. There's actually a little sensor that detects, so we control the RPMs, we control how fast the pump's moving. How much blood flow is occurring is based on the resistance of the circuit and patient, et cetera. So right now it's reading a flat line. It's like not reading a flow. So that can either be because things not pumping, not working, or it can be for another nuanced thing about this specific machine that we should be aware of. And it's actually that the sensor is not detecting any flow. It's actually out of gel to sense. So what that is actually, you guys see back here, wish we had a little more room, but the pump back here, if you want to come around.
I don't want to cause fear.
You guys can come all the way up if you want to, just because it's hard to see.
So in the back here is our pump head, and there's a little device, there's a little flow sensor within this black thing here, and it needs gel in order to sense how much flow there is, and right now it's out of gel, it's dried up. And this can happen if you have a patient who's been on for a long time. All of a sudden, everything's fine, the patients look fine, the stats look fine, and all of a sudden it starts alarming, and you see these lines coming across. It may be because it's out of gel. And so what we need to do is this one, never do this on your own because it can mess up the mechanics of the pump, but ask perfusion and then they can help re-jelly it. But we'll do it here. So we'll just turn it down, we'll put some more jelly so you can actually see what.
So typically when you're changing this out or putting the jelly on, you put down the flows all the way down first and then.
Yes, and sometimes perfusion is a little more adventurous, and they'll just do it kind of squirt it in there.
Oh.
So.
Yeah, you kind of rock it to the side without uncoupling it from the magnet and just shoot it in there.
So.
Yep, so undo that. Okay.
And then just put it on right here, you pop it out. Oh,
Yeah, it has to go under, unfortunately.
There's a little lip there, make sure it goes engages in the lip first. There you go. Okay.
Can I hit silent?
Okay, so let's try our sequence again. So turn it on. Okay, so we turned it on. We're gonna hit valve, and then hit silence. Okay. So now, what do we need to do? We need to turn the knob back to 0.
I'm already at 0.
Okay.
And then want to go back up?
So now you should be able to go back up.
Now I have flow, but I don't have RPMs.
There you go. So now you're back at 0.
So it has to say 0 on the RPM, not 0 on the flow, I guess?
Yeah, it's 0 on there. Okay, you're good. You start turning it up. You'll see the RPMs go up, and now we should start seeing our flow going up.
Okay.
And it's beeping because the flow is still low. Now we've reached a flow. What do you have there?
2040. Oh, flow of 0.3.
Okay. It's still pretty low. Go up a little more. This pump has been used in many teaching sessions. I think it actually may have some air entrained in it, and so that's why it's not giving us much flow. But yeah, so we gradually go up on the RPMs. It should give us our flow reading here. And so that's how we turn it on. So again, power on. It's going to say valve, alarm at you, hit valve, silence, turn back to 0, and then slowly go up to get your flow to come up. Cool. So what if, okay, so you've got your flow, let's say we're at 5 liters a minute, and the patient's, oh, actually, here's a troubleshooting thing. So what's another reason why we have low flow? We have high RPMs.
Well, a kink.
A kink, right? So run your circuit.
I usually start with the patient and work
Okay.
my way back.
Okay.
Already see a kink back here.
Good. So you ran your circuit, so you run your lines, and you saw a kink back there. So what happened with our flow? So it went up to 8.5 liters. So,
Good job. Patient saved.
so that could be external to the patient, or maybe the patient let their leg like that and kinked off with the cannula inside. So always run your circuit to see what your flow is. Very good.
I had a patient, when giving him his bath, when I laid him flat, I completely lost his flow. And we all ran in. We got him naked first. I had a PA and NP. All the nurses were in there. We couldn't figure it out until we would take the tubing and take the bed sheet and clamp the bed sheet. Here it was partially clamped, the tubing. So when I laid him flat, it completely occluded everything.
Oh.
But yeah, that was fun.
Yeah. So you guys can see there's a big kink rack here. That's why we weren't getting flows. So it's always important to run our circuit. Okay, cool. So we did loss of flow. Let's say you fix that, and patient's oxygenation is still poor. So we talked about it in our lecture. What would we look at?
FiO2 and blood flow.
Okay.
Volume status.
Yeah. So FiO2. Anybody want to come turn up our? So I'll mess with it. Okay. We'll come up and fix our FiO2 and. So there's a dial on there, right? So FiO2, you're going to 100%. Okay, so you did that and nothing changed.
You said also the blood flow. So
Okay, so blood flow, right? So we wanted to make sure the blood flow is okay, so we fixed our kink and our blood flow was, let's say it was okay. What else about this are you looking at to make sure that even if you turned it up to 100%, what do you want to see on this gas meter? You want to see some sweep gas going, right? So right now we're not hooked up to wall oxygen, so it says 0. But if you saw that as 0 and you're hooked up to wall oxygen, it means that you've turned it off. So you actually need to turn the dial to get actual oxygen going through the oxygenator.
Okay, gotcha.
Another scenario is that you just came back from CT scan. You just came back from CT scan, and now the patient is not oxygenating well. And so let's say we're not hooked up to the wall. What else could we be hooked up for gas?
Tanks.
A tank, okay? So let's say we're hooked up to let's say we want to be hooked up to the tank. You want to troubleshoot that for us?
It's off.
Okay, so it's off. Okay, so that's one problem. Okay, so let's turn it on.
Check.
Oh
my God.
Y'all scared me.
Part of the spin.
Oh my God.
It's just scared me more than anything.
I looked away. Scared the crap out of it.
That's the sheer terror part of ECMO.
What not to do?
Get me out of here. I gotta go.
Okay.
To your eye? Well.
Next session.
It's a long story. We'll wear goggles the next section.
Sorry about that. All right, so now your oxygen's on. Still nothing's happening. You hear it going.
Oh, yeah, it's not connected.
Okay, yeah. Right here, right? So our green line here. So we're gonna hook it up.
These are all tricks you can play on your pod mate, right?
No.
So probably not disconnected from here, but one that could be disconnected from here. Okay, not an oxygenator. Or let's say you turn it up to it's on 4 liters and you're all hooked up and you're still not oxygenating. Make sure your tank is actually full. If your tank ran out, it's not going to alarm. It's not going to tell you that. You're just going to see the patient desaturate. So All right, very good.
You know what's a good thing too to think about is the heater. So if you turn the heater off and we're not using the ECMO heater, we're using the K-pad, when you turn it back on, it reverts back to warming, so it's like 100.7. So you need to be careful that you turn your temperature back on your heater so you don't give the patient a fever. So that's something to think about too, when we're using the modified heater.
Yeah.
If they're bradycardic, I think hypothermia. Poor Renee, I think overnight had that patient where it like caught on fire or exploded
Oh my God, yeah.
and it overheated the patient.
Uh-huh. Yeah.
I couldn't hear about that.
We try to put that out of our minds. There was a malfunction with the heater, it wasn't.
Nothing anyone was doing
It wasn't
wrong.
anything, it was actually not the K-pad heater, it was the heater that comes with the ECMO circuit, and it overheated and caused the fever for the patient.
And she started bleeding like it
Pretty
was,
high
and she was
fever.
like 107 or I don't know. It was
really, really.
briefly.
So let's talk about that. So, right, if you have a patient who is either cold or they're hot on ECMO, that should raise your alarm bells. Like, why is that happening? That shouldn't be happening.
Right.
So how do we troubleshoot that? We look at our heater down here. So this circulates water through the oxygenator. Okay, so it's hooked up here. And so if we turn it on, oh, it's not plugged in. Oh yeah, perfect. All right, so we turn it on, and we can set the temperature much like we would any other device down here. Okay, so you should look at what the temperature is set at. If the temperature is like 36 degrees, 37 degrees, and the patient's temperature is different, you'd be asking why. It should be the same. It's very efficient at heating or cooling the patient down. And we had a patient, I think it was in bed 21 actually, where they were using a Foley that was supposed to temperature sense, and once they changed that out, the temperature was not, like he was having fevers and we couldn't figure out why because the warmer seemed to be working. They changed out the Foley for a different one, and then the temperature was normal, so it was a malfunction of that. It was kind of, what doesn't make sense, like ask why and change out your equipment. And like they said, one of the warmers was malfunctioning, and so that was causing some of the issues. So changing that out might be the right answer.
Yeah, we had another one where the warmer was malfunctioning, and when the perfusionist clamped, they had to clamp water tubing when they changed it out. The warmer was fine, but they never took the clamps off. So that's another reason why the patient was hypothermic.
All right. So let's say we have our patient is, we notice that they're pale. Yeah. Very plain. Let's say you start having you see air in the circuit. Someone wants to help. Yes, we clamp. Someone come clamp.
Come on, Emmy, you wanted to try it?
Okay, so how you can emergently clamp
Well,
off?
emergently, I'm trying to kick it off.
Yep, okay, you can't get off?
I have a clamp.
Okay, yep, so you can grab your clamps.
Yeah, I know how to open these.
Always look
Should we make
before you clamp. Occasionally people have scissors, which is I think you don't have scissors hanging on there now.
What is that?
Oh, scissors? Yeah, I don't
Yeah,
cut
like
it.
this. We always do that.
Very good. And then you can come over here and turn it off. So you see that the flow is 0, and good, you clamp it off.
So am I turning the actual one?
That's probably actually, should never.
You turn it down to 0. So see how it just spins?
Yeah.
So how do you make it actually turn down?
Push it.
Exactly, you push it in. And you'll see the RPMs go to 0. Cool. So when you're ready to come back on, we'll unclamp and go back up on our flows.
No, I didn't know that's
questions? And the other thing I'll mention about these, it's really finicky, is make sure that it's plugged in. It's part of the nursing safety checklist to make sure that that it's indicating that it's actually getting power. So this green button, that's plugged into the wall and the power source is working. Because these batteries can be very old and not functioning well. And if you have issues with the connection, obviously this can turn off. If the battery dies and there's no wall source, it's just going to turn off and you won't have any warning. It's just going to turn off.
How much reserve is it supposed to have, like, if you're traveling?
I think it's supposed to have like a couple hours, but we had one patient,
Yeah.
I remember who was with me in the hall.
We were moving.
Were you in the basement? Or?
Oh, no, we're talking about a different thing.
We were in the basement coming from CAT scan to the ICU, and we had to literally plug jump, go from plug to plug to plug because the battery was it malfunctioned and it wasn't.
Yeah.
All right. Okay, so let's say the battery goes out, the wall source goes out, there's a complete power failure. Patient's desaturating. 80.
Hand crank.
70. All right, hand crank, come on. Okay, so in the back, there should be a hand crank on there. That's another safety check if you have a patient on ECMO, is make sure that there's a hand crank hooked up, because they may not have put the one on there. There you go.
Chris, I'm sorry, they're saying they need the room.
Oh, yeah, we can get on there. All right. Cool?
Thank you.
Thanks, guys.
Thank you.
Thank you.
Thank you so much, that was great.
What's that? Over here, your coffee. Oh my God, where is this? Right here. Oh, there. Okay.
Chris, that was really good.
Awesome.
Thank you so much. I'm glad you made it.
You're alone.
Well, join the club.
Well, actually, I had this class from like 9 a.m. to 10 that's fine. And then yesterday, we're picking out in the bus stop. There's a guy with a really important meeting at 8 a.m.
Great.
So I thought I was going, I know.
So the clamp, the hand clamp itself, it's not normally here. I didn't see how it went.
I think we do.
Hooked it up?
Bill, I can call and say how long should we keep them for, but I don't think I did really like.
Whatever you can do.
Just your presence will be lovely.
Oh, I see. So is that you're moving up the
Yeah, you're moving over.
Yeah, just text.